around November, I think just right before Thanksgiving in the U.S. But here are some photos, besides some of the photos that Nato just showed. But when she was with us, and so as Nato had mentioned, she was heavily involved in the Staccato RCT project that we have. But she was super eager to learn as much as she could about uveitis from the proctor side, but also just a really passionate person, not only relating to uveitis, ophthalmology in general, and academics, but also just with respect to life. And so she enjoyed trying new things, and she enjoyed spending time with us. And so I think that these photos in particular here kind of demonstrate that. So actually, the shirt that I'm wearing is the shirt that KT got for me. She knew that I liked these kind of style of tie shirts. And so she was, again, just kind of speaks to the very thoughtful kind of person that she was. So I'll always treasure this. So I think, going forward with the CKPU conferences, I would like to dedicate a memorial lecture to KT. And so I think, in the future, we will have a memorial lecture dedicated to KT's remembrance, and that'll be one of the headlining lectures for future CKPU conferences. And I think that will kind of keep her memory going, as long as this particular conference series goes on. And it'll be an integral part of not only this particular conference, but in terms of how we remember her and a lot of the attributes that we seek to emulate in our own lives in terms of how KT lived her own life, with passion, with a lot of intelligence, and seeking to learn more about ophthalmology, about uveitis, and just about life in general. So, thank you.
Okay, so our next session would be a special lecture from Dr. John Gonzalez. So it's about a clearer picture of ocular infections. So insights from Proctor Foundation. So please, John, welcome, Dr. Gonzalez.
Thank you. Okay, let me see if I can find my talk here.
Yes.
I know things are a little off center, but give me one moment. I think now it should be okay.
Oh, okay. That's perfect, John.
Great. So thank you, Nato and Kay, for the kind invitation. Happy to chat with you all today from sunny Thailand. It's a lot warmer here than in San Francisco, and happy to be part of the remembrance for KT in particular. Like Kay had mentioned just now, I'm going to be talking about developing a clearer picture of ocular infections from the point of view of the Proctor Foundation. These are my disclosures. So as uveitis specialists, we're always tasked with determining whether or not a particular inflammatory process is infectious or non-infectious in nature. And the reason that this is important is that the treatment paradigms are entirely different. For an infectious kind of process, the management is typically with antimicrobials, whereas with the non-infectious process, management typically centers around immunosuppression. And the other thing that we have to be aware of also is masquerades. So syndromes that mimic one particular type of etiology, but in fact is an entirely different etiology with an entirely different management protocol than what we had initially assumed. First, taking a step back, let's talk about some problems with respect to diagnosing infections in general. So bacterial, fungal, and viral cultures have been the historic gold standard for diagnosing a particular infection. But the issue here is that many pathogens are difficult or unable to be cultivated with routine cultures. And so with pathogen-directed nucleic acid amplification tests, they have demonstrated consistently superior sensitivity compared to cultures, and they're now considered the standard of care for the diagnosis of infections, and that includes in the eye. One thing to keep in mind is that no infectious PCR assay is FDA approved, at least in the US, for handling ocular specimens. Directed PCR requires direction. That means that we have to know what we're looking for. So despite their superior sensitivity compared to bacterial, fungal, or viral cultures, we still have to know what we're looking for when you order this test, or you have to think about a particular pathogen to direct the particular PCR assay. And then another thing to keep in mind, despite the power of PCRs, is that some PCR assays are simply not routinely available, at least for clinical care. Now, let's talk a little bit about some problems in diagnosing infectious uveitis. So one is that the eye is small, right? The eye is tiny, and so its small size leads to small amounts of tissue that we're able to collect. Additionally, we have limited access to infected tissue. Additionally, the aqueous sample, which is most readily available to us in clinic, may not have a sufficient amount of inflammatory cells when the site of pathology is really in the posterior segment of the eye. And often there's a lack of a gold standard, which means that sensitivity and specificity for particular tests can't be defined. Additionally, with respect to diagnosing infectious uveitis, what is routinely clinically available to us, at least in terms of orderable tests, at least at our center, PCR we have for HSV, VZV, CMV, and toxo. Those are readily available, easy to order, but we don't have much else that's readily available to us. So if there's another pathogen outside of these four, we are going to overlook it. So what that means is that greater than 50% of presumed infectious cases, we fail to identify a pathogen. So often I think that our clinical acumen in terms of recognizing clinical features that are compatible with an infectious process are spot on. The issue is that we are often thwarted by negative test results. And the issue is not necessarily that a particular test doesn't perform well, it's that we're limited by the scope of our knowledge about a particular assay that we should or should not be running. So how can we address these issues? Well, when Thuy Dewan came to the Proctor Foundation, I want to say 5 years ago or so, although my timing may be a little off, she sought to bring the Proctor Foundation into the future. So what I mean by that is she is an experienced molecular scientist, and she took her knowledge and wanted to apply it to how we identify pathogens as a cause of infectious uveitis. So the first thing that she did when she got to the Proctor Foundation is that she took a bunch of archived vitreous samples that had been stored at the Proctor Foundation. These had been boiled and then frozen and were kept in a biobank at the Proctor Foundation. And what she ended up finding was that when she applied metagenomic deep sequencing, specifically high throughput DNA sequencing, she found that deep sequencing identified 27 out of 31 infectious agents that had been detected by pathogen-directed PCRs, and most of those were done in-house. In fact, at the Proctor Foundation, in-house pathogen-directed PCRs. So that was great. I mean, so there was a fair amount of fidelity between deep sequencing and our pathogen-directed PCRs. Then what she ended up doing was she took her metagenomic DNA sequencing prowess and wanted to see whether or not she could identify pathogens from samples that had turned out negative. And so what she ended up doing in this case was that she selected 36 randomly archived vitreous samples that had been previously tested by pathogen-directed PCR, and they had all tested negative. And remember, the samples had been collected because there was a strong clinical suspicion for an infectious process, but the PCR was negative. And metagenomic deep sequencing, specifically DNA sequencing, detected bacteria, fungi, and DNA viruses in 8 of these samples. And here you can see the specific pathogens that were detected. One thing to keep in mind is that the number of pathogens that we detected is likely an underestimation because DNA sequencing alone cannot detect RNA viruses. And the reason DNA sequencing was used in this case as opposed to RNA sequencing was, remember, the protocol years ago was any samples that were stored at the Proctor Foundation were boiled and then frozen. So RNA degrades readily under those conditions. So the samples were suited for DNA sequencing, but not for RNA sequencing. So again, likely an underestimation of the potential for pathogens in these samples that had been previously tested as negative by PCR. And here's a look at the metagenomic deep sequencing ocular workflow at the Proctor Foundation. So notice how it requires very little ocular specimen, anywhere from 20 to 50 microliters of fluid. That is amazing when you're considering that the aqueous, we're able to get anywhere from 100 to maybe, if we're lucky, 200 microliters of fluid. This particular test only requires 20 to 50 microliters of that fluid. And once the fluid is extracted, then either DNA or RNA is extracted, and you can see that it ends up going through the sequencer. The next step, which if you can see my cursor, is that it goes through this iterative filtering cycle where ultimately it goes through a series of quality control measures. And once you get a particular pathogen or genome that's identified, that is compared to known reference databases for pathogens, including for human host sequences. And so this process is more than just simply sequencing for any genomic material. Any genome that is identified then has to actually go through a bioinformatics pipeline. And then that has to be compared against a whole bunch of known reference databases. So besides the sequencing component that's done, then there also is this thought process that goes into it, bioinformatics, which takes a whole team approach at Proctor Foundation. So this little machine here doesn't spit out information, or doesn't spit out a result, I should say. There still is a lot of thought that has to go into determining whether or not there's a particular pathogen that's identified. But again, this basically shows how we're utilizing high throughput sequencing for ocular specimens. And so what I'd like to demonstrate is the utility of high throughput DNA or RNA sequencing in a few cases. This first case here is one that actually presented to us at the Proctor Foundation maybe by 3 to 4 years before Twee Dewan got to the Proctor Foundation. So this case had us stumped for years. This is the case of a 40-year-old German man. He had a 16-year history of uveitis. You can see that when he was in Germany in the 90s, he developed a body rash and fever. Years later, he develops uveitis in the left eye and anterior uveitis, characterized by ocular hypertension. Then a few years later, the right eye develops a similar uveitis. Then he immigrates to the US for work. As part of that process, he's required to get the measles, mumps, and rubella vaccine. Then he goes to a uveitis specialist in Los Angeles who thinks that the patient may have an infectious cause of uveitis based on the clinical features. And an AC paracentesis is performed with directed PCR negative for HSV, VZV, and CMV. So given those negative results, the thought is that this patient must have a non-infectious cause of uveitis, and so is commenced on prednisone and ultimately methotrexate, but never really achieves control of the uveitis. The patient then ends up moving to San Francisco for work, and his medication is discontinued, and the referral note that accompanies him asks us to consider potentially moving on to a biologic, specifically an anti-TNF agent, since he wasn't doing well with methotrexate. But our thoughts were were that he was suspicious for an infectious process, specifically a viral, and I'll get to why we thought that. And you can see that this patient ultimately had an aqueous paracentesis of the left eye, but you can see that HSV, VZV, and CMV are negative in 2012. But because he actually continues to decompensate with respect to inflammation now proceeding to vitritis, he ends up receiving an intravitreal phosphonet with minimal response, if any. A couple of years later, his right eye develops a vitritis. So an aqueous paracentesis is performed for that eye, and negative again by directed PCRs. A vitrectomy is performed for the left eye, negative again. And you can see here that we're kind of what we call spinning our wheels here. We're so convinced that he must have an infectious process, particularly a viral etiology, given the clinical features, given the fact that he has ocular hypertension associated with flares. But you can see that we're repeatedly negative on directed PCR for the most common viruses. And here you can see that, why we were thinking that he had a viral uveitis. He had features of iris heterochromia. You can see, in fact, he has frank iris transillumination defects. You can also see that he has keratotic precipitates that extend well above the corneal equator, and he has increased ocular pressure associated with some of his flares. So all of these features are super suggestive to us of a viral etiology. This is the reason why we didn't advance him to an anti-TNF agent like Humira, because we were convinced he had an infectious process. So we had a lot of banked specimens to work with, and Twee comes onto the scene, and she ends up taking a look at some of his banked specimens, runs it through high throughput sequencing, and she ends up uncovering a pathogen with a 9600 nucleotide base pair sequence. This is the entire genome for rubella. And so this patient had rubella the whole time. And in fact, with deep sequencing, because we sequenced the entire genome, we're also able to identify specific strains. And this patient actually had a strain that aligned most with one from Stuttgart, Germany. And this is exactly where the patient is from. So remember that this patient had developed a rash years ago before he developed uveitis. And that rash was likely rubella. Some people may say, oh, he got the measles, mumps, and rubella vaccine before he immigrated to the US. But this patient actually got wild-type rubella prior to getting the MMR vaccine. That was what that rash was about. And the fact that we can identify the entire genome tells us that this is wild-type virus and is specifically a strain from the region that that patient is from. And we've gone on to demonstrate how deep sequencing has been helpful in an additional 5 cases of rubella anterior uveitis. Interestingly, rubella shares a lot of similar phenotypes with phenotypic appearances, I should say, with other viruses, including some of the herpetic viruses. We can see dendritiform or stellate keratotic precipitates on confocal microscopy. We can see spot-like holes and endothelial infiltration, which is similar to what we can see with HSV. And we can see in these 5 cases that we had a very good coverage with respect to the genome of their particular rubella viruses. So really, really neat. One thing to keep in mind is because we're sequencing the entire genome, that allows us to identify potential antiviral resistance mutations. This here is for CMV, an entirely different virus than rubella, but one issue that comes into play sometimes for cytomegalovirus is that it can develop antiviral resistance. And so because we sequence the entire genome, we have the ability to identify antiviral resistance mutations and then tailor our therapy based upon those findings. Here's another case. This is a 45-year-old man with a 2-year history of uveitis. He had a biggest problem was blurry vision in both of his eyes, and he was referred to us from his glaucoma doctor for management of his uveitis prior to additional glaucoma surgery. And you can see that this patient had a history of glaucoma that was diagnosed in 2016. Then he developed cataracts in both eyes over the intervening years and required cataract surgery in both eyes. Then he develops uveitis in both eyes, characterized by an anterior uveitis, and it's being managed by the glaucoma doctor locally with just steroid eye drops. He ends up developing glaucoma in both eyes and requires glaucoma in both eyes. And then later, his glaucoma surgery is not doing well. I think they were trabeculectomies originally. And so he ends up having tubes placed in both eyes because he has uncontrolled ocular hypertension and persistent uveitis. So, and I think probably the trabs failed because of the persistent uveitis. So he's referred to us because he still has uncontrolled pressures. There is a need to get his uveitis under control before having additional glaucoma surgery. Interestingly, when he comes to see us, in the review of systems, we get a vague history of some headaches and maybe a little bit of memory loss, the wife says, but nothing else systemically going on. Other than that, he does happen to have this brain lesion identified on an MRI. And it actually turned out to be a pituitary tumor. At least that was the thought at that time. His medical management included steroid eye drops, glaucoma drops, and he was on testosterone for this pituitary tumor. He also had, as I mentioned, a little bit of forgetfulness. Social history was he was originally from Mexico. He also had some acneiform lesions on his chest and some gynecomastia. And here is that picture of the pituitary tumor. It was most compatible with a prolactinoma, and the thought was because he had actually prolactinemia, and he also exhibited gynecomastia. So this pituitary tumor was actually already well known to the folks in neurology and was thought to be entirely unrelated to his uveitis. Here's how he presented to us. So right eye 20/60 vision. He had large keratotic precipitates, mostly in Arnold's triangle. He had 1+ anterior chamber cells, 1+ anterior vitreous cells, no vitreous haze at this time. This little kind of white spot actually is an artifact. And in the left eye, counting fingers vision at 3 feet, large keratotic precipitates on the corneal endothelium in Arnold's triangle, 3+ anterior chamber cell, 2+ anterior vitreous cell, and 1+ vit haze. This here is actually, again, a artifact. Because of these large keratotic precipitates, and because he had an anterior and intermediate uveitis, we ended up doing confocal microscopy to see if any of these KP looked similar to large atypical lymphocytes, possibly compatible with vitreoretinal lymphoma. And you can see that he has these kind of large nebulous hyperreflective lesions, but nothing that looks compatible with large atypical lymphocytes. He has a little bit of macular edema in the left eye, and fluorescein angiography was notable for maybe some punctate hyperfluorescence in the mid-periphery, maybe compatible with some window defects or some mild, actually, vascular leakage. But overall, there was nothing really particularly compelling. And so, in summary, this was a gentleman with bilateral granulomatous anterior and intermediate uveitis, and the differential diagnosis is quite broad, you can see here. And if we take a look at infectious etiologies, these weren't super high on our list, but we still developed a really broad differential here. His testing for quantiferon TB gold was negative, RPR and FTABS was negative, a CT of the chest was negative. So at this juncture, because of this patient's anterior and intermediate features, this was thought to be just non-infectious, clinically, and so he was commenced on oral prednisone. And so the thought was that he would probably get a lot better. And a week later, this patient shows up and he actually looks worse. And so you can see that in the anterior vitreous, we had these large kind of clumpy inflammatory cells. So this was certainly worse than what he looked like a week prior to starting the prednisone. And taking a look at the posterior segment, his pressures are out of control. And remember, we're trying to get his uveitis controlled so that he can have an additional glaucoma surgery. His inflammation overall is worse in both eyes. And take a look at the posterior segment of this left eye. He has now evolved to this really chunky, very chunky opacities within the vitreous. And you can actually see really well that they look like these pre-retinal precipitates. At this juncture, my thoughts change a little bit. He looks so much worse with prednisone. His macular edema, by the way, is also worse. This can be something that could be compatible potentially with vitreoretinal lymphoma. He's got so much cell in the anterior chamber. It's easy enough for us to do an AC tap and just send that for flow cytometry. Actually, in this case, I think what we ended up doing was just, as you can see here, just sending it for cytopathology. And there was a lot of cellular degeneration due to drying. So cellular degeneration can certainly be seen in lymphomatous cells exposed to high doses of steroids. So, the question for me was, is this truly cellular degeneration from drying, or are these what are known as smudge cells that can be seen in lymphoma? So again, the picture is not quite clear. And by the way, we were able to save about 20 microliters of fluid for deep sequencing, which takes a little bit of time to process at Proctor because it's still a research protocol. Now, at this juncture, this patient is decompensating, and I want to show you this.
Would you like to?
Oh, yes, thank you.
Recording stopped.
Thank you, Netta. Thanks for stopping the recording. I'd like this not to be shared outside of this particular forum. But what I want you to notice is that when we have this gentleman, so now he's admitted to the hospital, you can tell, because he actually mentally was decompensating so rapidly. I was concerned he was going to pass away. So he gets admitted to the hospital. And as we have him try to look to side. Notice his mouth and these rhythmic mouth movements, and sort of he's blowing out with his lips. So this particular feature we'll get to in a moment. But at this juncture, we have neuro-ophthalmology on the team. And the patient ends up having a vitrectomy.
Can record on?
Recording can go back on. Thank you.
Recording in progress.
At this juncture, the patient's able to get a vitrectomy because he has so much vitreous cells. And again, remember, a lot of the processing is devoted towards processing for lymphoma. And remember, he has a lot of CNS decompensation. I have a suspicion he could have possibly lymphoma. And so the cytopathology shows that there is no evidence of a lymphoproliferative disorder in general. So we're stumped as to what is going on here. And, differential still could be potentially maybe this is sarcoid with CNS involvement. And so remember that we had fluid. We had 20 microliters of fluid. It finally gets processed. And Dr. Dewan is able to identify a particular genome for a pathogen. And that pathogen is Tropharima whipplei, so Whipple's disease. So we get this diagnosis and we tell cytopathology to go back and look at their specimen and now use PAS staining, and they're able to identify foamy macrophages and PAS positive granules. So this is all compatible with Whipple's disease. CSF cytology, in fact, shows PAS positive foamy macrophages. CSF PCR is positive for Whipple's. Serum PCR is positive for Whipple's. He ends up getting IV ceftriaxone 2 grams daily for a couple of weeks, and then he's going to be on doxycycline and hydroxychloroquine forever for the rest of his life. And you can see that with antimicrobial therapy, appropriate antimicrobial therapy for this specific pathogen, he's doing so much better. If we can stop recording for another moment.
Recording stopped.
And you can see that he doesn't have these atypical rhythmic mouth movements anymore. Now, he has a lot of problems with ocular motility, and that's not going to get better. But he overall mentally was doing significantly better, and the disease was entirely eradicated from his eyes. His uveitis was gone after that. So, I have always told myself that if I ever
start record now, sorry, John.
Thank you.
Recording in progress.
I've always told myself that if I ever came across a case of Whipple's disease, because it's so rare, I would retire. And so I may have to retire now, but it's one of the greatest mimickers. It can be a masquerade syndrome by virtue of its protein manifestations. This patient had absolutely no GI symptoms, and he had very mild headaches when we first met him. So Whipple's was the first thing from our mind. It wasn't until this patient decompensated and developed those atypical oral movements when he was with ocular motility, and those are known as oculomasticatory myarrhythmias. So by the time those developed, yes, it may have been obvious to some people, but I really feel that he would have died by that time if we had waited any longer. And so remember that we were able to diagnose Whipple's from just 20 microliters of aqueous fluid. Pretty impressive. Okay, so last case here. This is a 33-year-old man with 1-year history of uveitis, chief complaint of bilateral painless cloudy vision and floaters, and he was referred to us for management of uveitis that was refractory to steroids, and there was a high suspicion for an infectious etiology, though numerous infectious tests had been negative. So you can see here that he had extensive testing, but still no leads. Past medical history of multiple sclerosis. He had a medication history of rituximab for his multiple sclerosis, but he did not get any better after rituximab. So what he ended up doing against the advice of his doctors was that he traveled to Mexico so that he could get hematopoietic stem cell transplant for his MS. And he ended up, while in Mexico, before he was able to get the stem cell transplant, he ended up developing fevers, respiratory difficulty, and that delayed his treatment. Eventually, he was able to get that stem cell transplant. Then he ends up developing cloudy vision in the left eye, which was never evaluated by anybody. 4 months later, he develops cloudy vision in the right eye, and he started on prednisone, and this actually exacerbated his cloudiness vision. So he comes back to the U.S. right away because his vision's doing worse, and he gets an anterior chamber paracentesis, which is negative for HSV, VZV, CMV, and toxo. He ends up getting a second anterior chamber paracentesis because there's such a strong suspicion that he could have an infection. negative this time around for bacterial and fungal cultures. Then he gets a third anterior chamber paracentesis, which is negative on universal 16S ribosomal RNA. So he's had every single test to identify an infection, and everything's coming out negative. So he's sent to the proctor for help. And you can see here that he's got a ton of anterior chamber and anterior vitreous cell. He's got posterior synechiae as a sequela of uncontrolled inflammation. By this time, this patient's been on courses of prednisone as well as periocular steroid injections to no avail. So we perform an anterior chamber paracentesis in clinic, and some of the fluid is sent off for routine processing, which is negative for HSV, VZV, CMV, and toxo. This is just, a summary of prior testing. So negative for HSV, VZV, CMV, and toxo, negative on a subsequent TAP for bacterial and fungal cultures, negative on a third TAP for 16S ribosomal RNA. And when he comes to proctor, he ends up getting anterior chamber fluid sequenced, which ends up showing leptospirosis. So you can see the entire coverage of the genome for Leptospira centarosi. And you can see here that the coverage was quite good. There was no other pathogens that were identified in that fluid. So really, really impressive. Leptospirosis is not something that we routinely see at all in the United States. And you can see here the worldwide distribution for leptospirosis. And, again, this is not something that we identify in the US. But in Mexico, it's very common. And remember that the patient had traveled to Mexico for stem cell transplantation. So the way that leptospirosis uveitis is typically diagnosed is either with dark field microscopy, immunofluorescent microscopy, light microscopy, microscopic agglutination test. You can do PCR, and then there's ELISA. But remember, you have to be thinking of leptospirosis to identify it. And these tests, by the way, are not perfect. They can still overlook leptospirosis. So, this kind of shows the power of deep sequencing to identify pathogens. One other thing that deep sequencing can help us with respect to ocular infections is identifying attributes associated with pathogens. What I mean by that is, here we have a patient with conjunctivitis. Is this infectious or maybe non-infectious conjunctivitis? And if it is infectious, is it viral or non-viral? And here's another patient with conjunctivitis. Looks almost exactly the same as the other patient, right? Could this be infectious or non-infectious, viral or non-viral? Sometimes we're not always able to recover any of the pathogen, but we may be able to look for host responses as clues. And so here's an example of how the host transcriptome distinguishes between adenovirus conjunctivitis from non-infectious conjunctivitis. And you can see that these samples from people with adenovirus tend to cluster around these specific genes. And you can see that some of these genes are actually downregulated in non-infectious conjunctivitis. And if we look at, and that was, by the way, for adenovirus versus no viral infectious conjunctivitis. Here we have adenovirus here in gray, and we have a couple of cases of Vitiforma corneae, which is a parasitic fungus. And even between fungal versus adenoviral, between different etiologies of an infectious process, we can see that there's clustering about specific genes related to cell adhesion, as well as matrix metalloproteinases. So very, very interesting. So even if we can't identify the specific pathogen in some cases, we can still find host response features that indicate what the pathogen might be. And so here's kind of a summary of how we're utilizing high throughput sequencing at the Proctor Foundation. But in short, to summarize things, the utility of deep sequencing is pretty powerful in detecting infectious pathogens in uveitis. Deep sequencing reliably detects and quantifies common and rare pathogens. Deep sequencing can identify strains as well as resistance, antimicrobial resistance features. Its unbiased nature of RNA deep sequencing allows for an expanded scope of pathogen detection, including fungus. And then deep sequencing identifies infection type specific local host transcriptome signatures, even when we might not be able to recover the actual pathogen itself. So thank you all for your attention. I'm lucky enough to work with a great team at the Proctor Foundation, and thank you again.
Thank you, John. That is excellent talk.
Thank you.
Yeah, so we're looking forward for the development of MDS in this world and maybe possibly use it in Thailand in the future. Okay.
Right.
We have some collaboration with the conjunctivitis research
Exactly.
on the on this project
Right.
with Chulalongkorn, Khon and many places in Thailand.
Right.
So we're looking forward for that.
Yeah.
Thank you so much, John.
My pleasure.
Yep. Yeah, I think we should move on, Jay.
Right. Okay. So our next session would be the presentation of interesting cases associated with all the viral etiology cases. Okay, I will give the microphone to Dr. Butsarat and Dr. Vijak. Are they here yet? Hello.
Yes. Yes.
All right.
All
Okay.
right. Hello and welcome again.
Please.
I'm Dr. Wijat from Chulalongkorn University Hospital. Welcome to the case-based symposium. And I am one of the panelists of this session, and we are very fortunate to have Dr. Consulate to join us as a panelist. And we also have Dr. Busrat, who was a former retina and uveitis fellow at Chulalongkorn University Hospital, and he is now working at Ang Thong Hospital, and he is also part-time faculty here at Chula. He's just get married. And for the first part, there are 4 cases. Each presenter will have 7 minutes to present and 3 minutes for discussion. And if any audience has any comments or questions, please feel free to type in the chat box, and we will discuss at the end of each case. Dr. Busrat, why don't you introduce our first speaker?
Yes, my name is Dr. Busra. So let's start to the session. At first, speaker is Dr. Panutat Chernkhwansi. He is our retinal fellowship right now. Are you ready, Dr. Panutat?
Yes, thank you. Okay, can you see this my share slide?
Yes.
Okay. Good evening, everyone. I am Dr. Panutat Chernkhwansi. It's very honored to be here. I'm in the fellowship of the Vitreoretinal Unit of the King Chulalongkorn Memorial Hospital now. Today, I would like to share the cases of the viral-associated anterior uveitis in the uveitis clinic in the KCMH. First, I'm gonna start with the group of the CMV causing anterior uveitis that confirmed by the aqueous PCR for viral multiplex. First case is the Thai female, 35 years old, come with the recurrent eye pain with decreased vision and intraocular pressure rising in the left eye. From serum examination show diffuse of the keratic precipitates. As you see in this picture, there are pigment KP combined with small to medium KPs. And if you see the KP pointed by yellow arrow, it shows the small pigment at the edge of the medium KP. This feature was likely to be seen in the CMV related. Oh, sorry. And next is the case of the young adult female complaining first episode of eye pain with intraocular pressure rising in left eye. She also had feature of the atopic that creates the list of the viral associated. The examination showed diffuse of small to medium pigment KPs combined with some area of the stellate KPs. Okay. Next case was referred to KCMH with recurrent eye pain with glaucomatic disc. From examination, show area of the stromal edema in the superior cornea. Combined with diffuse pigments KP and small to medium KPs that show characteristic of pigment at the edge, same as shown in the first case. Sorry for. Next is confirmed case of the CMV anterior uveitis, show the intraocular lens precipitate. And the feature of area of iris atrophy from invasion of virus into iris stoma and induced area of the occlusive vasculitis, which leads to ischemic necrosis of the iris. This case also show diffuse 5KPs that show the blanching or stellate appearance that we call stellate KP. Even rare, but some cases show the feature of the posterior synegia, as you see in this picture. This patient had focal area of posterior synegia in the superior, and if you see in the inferior portion of the cornea, there's an area of the stromal edema. Combined with diffuse 5 stellate KPs that caused by cytomegalovirus that affected endothelium. Next was the case of herpes simplex virus anterior uveitis. This Thai male with history of the HSV with anterior uveitis in the right eye and on oral acyclovir for about 1 year. After he lost follow-up and acyclovir cessation about 2 months, he developed clinical of the eye pain. Which show the dendritic lesion at the infranasal of the cornea that gave clue of the herpes simplex virus pathogen. Next one is the cases of the anterior uveitis causing by the herpes zoster virus. This patient referred to KCMH with clinical off and on red eye with pain. The examination showed diffuse area of the melting iris atrophy. This is one of the clues to suspected to viral cause. Diffuse 5KP with pigment KP was seen in this case. Also with a pseudo-dendritic lesion at the cornea. The aqueous PCR confirmed for herpes zoster causing in contrast to the two dendritic in the herpes zoster virus cases. The varicella zoster virus pseudo-dendritic are smaller in size, elevated without central oscillation. They do not have the terminal bulk and relative lack of the central staining. Herpes zoster will sometimes cause the other corneal lesion characteristic, like in this case. Like in this case, the female patient with clinical and history suspected for herpes zoster virus causing anterior uveitis. She have chronic anterior uveitis with the intraocular pressure rising combined with the decrease in the endothelial cell count with time. She has had multiple aqueous taps for viral PCR and finally detect for the herpes zoster virus from the third procedure. With the huge geographic outer lesion with scar mimicking the band keratopathy in this picture. This case warning us that the aqueous tapping time is the timing is important to detect the pathogen. So now let me sum up the clue to suggestion for viral causing anterior uveitis. From history, that the patient had the history of the unilateral anterior uveitis, the recurrent episode, the IOP rising, the diffuse area of the KP, iris atrophy, and reduced endothelial cell count. And combined with the examination finding like and this picture, the herpes simplex virus, we can see the many of the KP from the 5 stellate pigment or sometimes greasy KP. The iris may show the patch area of the atrophy, and if we see the true dendritic lesion that characterized by terminal bulk and stain with the central oscillation. It leads to plan management for the herpes simplex virus. In the herpes zoster virus, they also have the multiple KP feature. The iris may show the severe sectoral atrophy from the viral invasion. And some corneal lesion clue that we are seeing in the example case like pseudodendritic and geographic ulcer, like in this picture. And the CMV, we can see some characteristics of the KPs that stellate, characteristic KP like stellate and coil-shaped KPs. The iris that show motting or diffuse area or atrophy of the iris and often come with the area of the stromal edema from CMV inducing endotheliitis of causing endothelial cell reduction. This all remind us that patient history and especially finding clue from the examination is very important for our time. Thank you for your attention. And sorry for it's not that smooth.
Thank you, Dr. Panutat, for a nice overview of distinguishing features that will help differentiate causes of viral-associated anterior uveitis. I would like to add something about the features that for the herpes simplex or varicose zoster, you may find that the corneal sensation is reduced compared to CMV anterior uveitis. And for CMV anterior uveitis, the anterior chamber reaction tend to be lower than the herpes simplex and varicose zoster virus. Yes. And anyway, I think it's important to recognize all the clinical features to help us to think about the course. Any comments from the panelists? Dr. Gonzalez?
No, I mean, in general, I agree with all of that. I think it was notable, I think on the zoster case, Dr. Panutak, that you had mentioned that it required 3 paracenteses to arrive at the diagnosis. So I think that you know, it's often we need to trust our clinical suspicion. So obviously your clinical suspicion was high that this was an infectious process. And even after a second negative tap, you still didn't give up because, you know, remember the rubella case I had mentioned where after 1 negative tap, the patient was thought to not have an infectious process, was commenced on immunosuppression, right? And which is the wrong course of treatment for an infectious agent. So, you know, we need to trust our clinical acumen or our clinical suspicion, I should say, rather, which you did in that one case. And so often, sometimes when we do a tap, it's either the virus is not there at that time or the virus is below the threshold of detection. So it you know, falls on our shoulders to keep trying to find the pathogen. Yeah.
Yeah, may I add up something? John, you bring up the very good point. So I would like to ask you and also the panelists that nowadays we see more and more the infiltration of like KP like on the IOL surfaces, and we see more and more it's going to be like the infectious pathology. Do you have any comment on this?
I don't in particular. I mean, I think that I'm not certain what is happening on the IOL that allows for the accumulation of precipitates in general. I mean, there isn't anything that is particularly that can harbor an infection. So it seems like there's just, you know, those are probably sterile inflammatory cells, as opposed to where you can get an endotheliitis, right? You get frank endothelial infection from a virus, but I don't have a good explanation right now. And so I think we'd have to probably at some point down the road be able to extract some of those IOLs and see what is going on, whether we submit that to electron microscopy or something. You know, certainly when you have a bacterial pathogen, there can be a biofilm on the IOL, but I don't know what's going on for a viral etiology.
We do have some cases confirmed by the PCR, but I think that may be the next question for further research on us. Okay, thank you.
I have a question to Dr. Gonzalez or Dr. Busrat. When would you perform diagnostic anterior chamber paracentesis? You perform in every case that has a highly suggestive features?
At Proctor, we do. I mean, nearly everybody gets an anterior chamber paracentesis nowadays. I mean, unless it's like very clear that it's likely infectious, but whenever we have a suspicion it's infectious, everybody gets an anterior chamber paracentesis.
Yeah.
Because here in Thailand, we have a limitation of the affordability of the anterior chamber paracentesis is not available in every hospital. So maybe, do you think we should go ahead and start antiviral by ourselves?
Well, I mean, so I think in those cases where you can't do a paracentesis and directed PCRs, then you'll just have to use your clinical acumen. And yes, then you would do a trial of antivirals and see if they get better. And if they do, it's perhaps HSV or VZV. Obviously, CMV won't respond to acyclovir or valacyclovir. And I guess you could, if they, what we used to do in the old days, if somebody did not respond to those medications, we would suppose then it was perhaps CMV and then submit them to valganciclovir and see if they respond. But, what if it's rubella? Then you won't know. But rubella is a lot harder to diagnose. But for the herpetic viruses, I think that approach, just doing a stepwise trial of antivirals is reasonable.
All right, thank you. Any comments from Dr. Busrat?
Yeah, I think if some case that we don't know exactly what is it, aqueous tapping is very important. But sometimes some clinical is show more seems to be more obvious. Like the patient comes to us with a zoster lesion in the face, so and anterior uveitis. So I think we don't have to do aqueous tapping.
Yeah, I mean, I do agree with Dr. Bussarat about the case. So that presenting with the history of like zoster, skin lesion on the dermatomal fashion. So in that kind of patient, I think anterior chamber paracentesis maybe not have give more information or different in treatment option. So I would go straight forward to treatment if the case got skin lesion in the past. So, but the picture of KP, I think, is very difficult to differentiate between type of viral infection. Sometimes it look like stellate, sometimes it look like coil shape. It could be CMV. Maybe the AC paracentesis instead for PCR got indicated in that cases.
Yes.
Thank you.
Let's go to the next case. The next case is from Dr. Arisala Galvician. Now she is a third-year resident from KKU Eye Center. If you're ready, you can start your...
Hello everyone. Today I would like to present an interesting case of anterior uveitis. This is a case of a 69 years old Thai female who presents in our clinic with a history of her right eye got redness, pain, and decreased vision for 2 weeks. 4 weeks prior to visit, she had multiple vesicles on right side face with painful sensation, no vision loss, and red eye. She was diagnosed herpes zoster ophthalmicus on her face. 2 weeks later, she had improved of vesicle on right side face, but developed eye irritation, redness, pain, and blurred vision of right eye. Her left eye is normal. She denied underlying disease, ocular trauma, and ocular surgery. At presentation, we reveal hyperpigment lesion over skin follow the ophthalmic division of trigeminal nerve dermatome. On examination, visual acuity on her right eye was 624, with intraocular pressure is 23. We found that she had decreased corneal sensation, and segmental of iris atrophy. Diffuse of pigment KPs were observed only on her right eye. Close-up of the picture of the former slide show characteristic of stellate KPs. As you can see here, anterior chamber cell and flare are difficult to be observed. The fundus look normal in both eyes of this patient. So in summary, this case is unilateral granulomatosis anterior uveitis with increased intraocular pressure, iris atrophy, decreased corneal sensation, and a history of dermatomal zoster. According to the classification criteria for varicella zoster virus anterior uveitis from Sun Working Group, this patient have met all three criteria for the diagnosis of varicella zoster anterior uveitis. First, she had evident anterior uveitis, and it is unilateral with evidence of varicella zoster virus infection in the same eye, described by sectoral iris atrophy in the patient older than 60 years old and concurrent dermatomal herpes zoster. Herpes zoster affects 20 to 30% of the general population, but only 10 to 20% of these patients will have herpes zoster ophthalmicus. Among these developed anterior uveitis, about 60%. In case of herpes zoster anterior uveitis, most of the patients may have a history of dermatomal zoster, and this lesion will be a great clue to make a diagnosis. However, 6% of the anterior uveitis patients may not have a history of sclerosing. And these 6% didn't notice dermatomal zoster, usually men younger age, non-white, more with uveitis, and less often normal iris. In contrast of the present case, this is another patient with varicella zoster anterior uveitis. He presents with a month of unilateral acute iridocyclitis with increased intraocular pressure. On examination, found correctopia, oval shape of pupil with iris atrophy. So in his left eye is normal. Again, the clue for diagnosis is a history of herpetic dermatomal skin lesion in the past 10 years. Granulomatous cluster of small and medium-sized KPs in arc triangle, segmental iris atrophy with or without corneal scar, suggestive of herpes simplex or varicella zoster infection. This is the picture of herpes simplex type-2-related anterior uveitis confirmed by PCR. Active keratitis may not be present during an episode of viral anterior uveitis. Corneal scars are important clue that suggest possible previous viral keratitis, likely caused by herpes simplex virus or varicella zoster virus infection in the absence of a history of trauma. And this case is from our clinic. We confirm CMV anterior uveitis by PCR, and you can see multiple nodal-like KPs with halo. So they may present as the following: granulomatous cluster of small and medium-sized KPs in arc triangle with or without corneal scar, suggestive of herpes simplex or varicella zoster virus infection. Secondly, Poner-Schwarzman syndrome with few medium-sized KPs, minimal anterior chamber cell, and extremely high intraocular pressure. This is mainly associated with cytomegalovirus. Thirdly, foot uveitis syndrome with 5 stellate KPs diffuse distribute over the corneal endothelium with diffuse iris stromal atrophy, but without posterior synergia. It associated mainly with rubella or cytomegalovirus infection. As their ocular manifestations are variable and may overlap, viral anterior uveitis can pose a diagnostic dilemma. Thus, quantitative polymerase chain reaction from aqueous human examples are performed to confirm the etiology and determine the disease severity as this impacted treatment. Thank you for your attention.
Oh, thank you. That are other case presentation of varicella zoster virus. And I would like to ask the presenter, did you work up on the underlying systemic disease for the patient?
No underlying disease.
Yeah. From my own experience, a lot of time I got a newly diagnosed from when the patient first presented with herpes zoster optimicus, and sometimes the patient is diagnosed with diabetes mellitus or have the positive anti-HIV. So maybe sometimes maybe we have to look for that. Okay. Any comments?
I would
That's
say
very interesting. Oh, sorry, John, go ahead.
Thank you, Kate. I would say yes. I think that we also have to recognize that the efficacy of Zostavax or Faravax, whatever is given to children, wanes, and so there are, we're finding that the prevalence of HZO in younger individuals, even without underlying conditions, is happening younger and younger, actually. So, yes, I think the teaching had been that, look certainly for an underlying condition, whether it's HIV or diabetes, but many younger individuals actually have no underlying health conditions, but still develop zoster. And I think it's just because of the waning efficacy, of the virus, of the vaccine. And that certainly has been seen also with the older version of, and I forget their names now, but the older version of the zoster vaccine, which is less of an issue now with Shingrix, at least in the US. Shingrix provides a longer duration of efficacy with respect to protection from recurrent zoster. But yeah.
Is that Zostavax, the consulate?
Sorry?
Zostavax.
No, so the one that's, so in the US, Zostavax is, Zostavax, if I remember correctly, was offered to adults. Faravax was offered to children. So, but now for people that are 50 years of age and older, Zostavax is no longer offered because it's not as effective as the newer Shingrix, which Shingrix is not live attenuated virus. It actually contains a couple of key proteins to stimulate an immune response. So Zostavax and Faravax contain live attenuated virus. You may not give those to immunocompromised individuals, but the new Shingrix, which has better long-term protection, does not contain any virus at all. And that's what's being used currently in people that are 50 years of age and older in the US.
Okay.
I mean, just to mention about this case, this is just an example of case that we didn't do the AC tab for the diagnosis and also start the treatment without the PCR result. And pretty sure that is varicella zoster from the typical presentation and history of skin lesion. And just, we touched about the underlying and the, demographic data of the antiviral uveitis. I just wondering about maybe ask anyone who knows about this for CMV anterior uveitis host. Mainly that I saw is like typically male, healthy male, like 40 to 50 years of age. And yeah, I mean, I think more than 50% of my patients that got CMV positive is like male, healthy male, like 40 and very like super healthy. Don't know. Is that relate to any of that? Like CSCR in the retina is also associated with this typical typical feature of horse. Do you have any comments for this, John?
I mean, I don't. I mean, I think we have a mix, and I have to go back and look at our kind of just our data, but
right.
But I have a patient who originally, when she came to us, she was 16 years old at that time. She's originally from Yemen, and then we have. I would agree, maybe half her, 40s or so, totally healthy. I totally agree with you that everybody's healthy, no obvious immunocompromised status. But I would say maybe 50% of my patients are women of, usually in their 30s to 40s, sometimes 50s. I would say most of the patients tend to be East Asian. And so we still don't know why that seems to be the biggest case, why East Asians are affected more often than other types of people.
Right. Okay. Thank you.
Okay, may add up a little bit on this. So I think you mentioned about the male maybe predominate in the CMV. I also think so because of in Chulalongkorn University we see a little bit more. It's not like 80, 20, something like that, but a little bit more. It might have some reason behind and when we all know that the atopic eye have more likely to have the viral infection and the uveitis, that because of the microbiome that we explained that the microbiome is different in the atopic eye, right? So maybe some reason behind. So that's a good question for the next research as well. Thank you.
Well, I think we move to the next cases. The next cases is from the Dr. Kittipong Thapsuwan. Now he is as a corneal and refractive surgery fellow at Chiang Mai University. Are you here and ready to?
Okay, yeah, I'm here. Okay, may I share the screen, please? Okay, so can you see my slides?
Yes.
Okay, so good evening, everyone. I'm Dr. Kittipong Thapsuwan. So I'm here on behalf of the uveitis units of Vajira Hospital, and it's an honor to be invited to present an interesting uveitis case here by courtesy of Dr. Sutra. So without further ado, let us begin. This is the case of a 79 years old male with a sudden onset of painful blurry vision in his left eye. The past ocular history is quite long. In June, he underwent a cataract surgery, but unfortunately, it was a complicated case. So he also underwent a vitrectomy with the sulcus placed IOL, and also he had the retained lens material in the vitreous cavity in his left eye. In July, after planar vitrectomy and lensectomy, at that time, he developed the acute granulomatous hypertensive anterior uveitis with retained lens material in his left eye. At that time, IOP was 30, so he was diagnosed by the glaucoma specialist that he has the lens-induced uveitis in his left eye, and post-planar vitrectomy and lensectomy was done. And after vitrectomy was done, the IOP was not high. In August, it was 1 month after the vitrectomy. The patient developed secondary ocular hypertension with the IOP of 27 without any sign of inflammation. And at that time, he also diagnosed with the steroid-induced glaucoma in his left eye. Of note, he was on topical steroids all the time after the lens surgery and the vitrectomy. So the IOP was controlled by the glaucoma specialist with maximum anti-glaucomas, including oral acetazolamide. In September, the case was sent to the uveitis clinic for a consultation because the patient revisited with the acute painful blurry vision in his left eye, and at that time he's still on the steroid eye drops, which is the 1% prednisolone or 1% predford, and topical anti-glaucomas, oral acetazolamide. Underlying medical condition of him was hypertension and dyslipidemia. This is the ocular examination at the time of consultation. His VA, his visual acuity was 15/200 in both eye. We will focus on the left eye, which is the problematic eye because he has the dense cataract in his right eye. So at that time, the IOP in his left eye was 28, and he presented with diffuse corneal edema with diffuse mud fat KPs. The AC cell was 2+, 1+ flare, and the iris has the moth-eaten iris atrophy picture, and the IOL was sulcus placed. You can see that the keratic precipitates were kind of looked pretty granulomatous to us, and the posterior segment, this is the vitrectomized eye. The vitreous cell was 1+ with the vitreous haze of 1+, and he also presented with the peripheral retinal infiltrate with retinal hemorrhages along the vessels and the vascular cuffing. And also he has scattered dot hemorrhages in the midperipheral retina. So we're coming to the naming of uveitis. The uveitis naming in this case would be 79-year-old male with sudden onset of unilateral granulomatous hypertensive panuveitis in his left eye. So we come to a differential diagnosis of the unilateral granulomatous hypertensive panuveitis with retinitis in this case. The first group is the infectious uveitis, which is might be the viral, the HSV, VZV, CMV, syphilis, tuberculosis, or toxoplasmosis, which can also present with granulomatous uveitis. The second group is the inflammatory causes, which in this case, it could be the lens-induced uveitis or might be the sarcoidosis as well. And the third group is the masquerade syndrome, which is it can be the primary intraocular lymphoma. So we moved to the investigations. The uveitis workup was done, and he was immunocompetent to us. The HIV test was negative. Troponin test was also non-reactive. The quantiferon TB gold was negative. The chest X-ray was unremarkable, but the aqueous PCR was positive for CMV. So the diagnosis was CMV panuveitis. So he presented with granulomatous anterior uveitis with the picture of the CMV retinitis in his left eye. So we started the intravitreal ganciclovir in his left eye weekly until the lesion is stable. So here you can see that the retinitis in the inferior retina is subsided with some scars left in the area around here. So compared to the picture that we presented to you guys before, so the retinitis is subsided. After 4 weeks after last injection or 3 months later, he developed an episode of granulomatous hypertensive anterior uveitis again with the IOP of 40. And the finding is pretty similar to the previous episode of granulomatous anterior uveitis before. So he also has the diffuse corneal edema with the mud fat KPs, and the fundus this time, there was no evidence of any active retinitis in his left eye. And aqueous tapping was done again, and PCR were still positive for CMV. So at this time, the diagnosis was CMV anterior uveitis in his left eye, and we put him on the topical ganciclovir and 1% predford, and the patient was in remission after a month of treatment. So in conclusion, let me sum up my main points here. So first, the chronic steroid use might increase the risk of developing concurrent CMV anterior uveitis plus CMV retinitis in the vitrectomized eye, because we suppose that it was the same chamber. And there are also several reports of CMVR following intraocular steroid injection and implants, but to date, there's no current report of topical steroid-induced CMV retinitis, which we hypothesize that long-term use of topical steroids might induce a local immunosuppression, and that led the extensive CMV infection to manifest. Thank you.
Interesting case. Dr. Sutra has done a great job of teaching you. I have a question, and maybe it's either for you or Dr. Sutra can answer again about this concept of the topical steroids inducing CMV retinitis. I haven't heard of that before. I agree with you that certainly intraocular steroid implants have been associated with that, but
yeah. Yes, okay, go ahead. Sorry.
No, please. No.
Yes, because we just review the literature that have a report that have a report of CMV retinitis developed after the injection of the steroid and also the implantation, and that has some report that they have after the subtenon injection of the steroid also. But I did not see evidence of the just a topical steroid. But in our case, I have a little bit complicated because I have a larger posterior capsule with a vitrectomized eye, so maybe increase the risk of the CMV retinitis in this case. Yeah, I'm not sure. Yeah.
Mm-hmm.
Yeah, may I have some comment on this?
Yeah.
I think it's very important things, and I think it's good to think about this. But let's say one thing I would like to know that because this case is IOL in sulcus, which of the IOL that they implant in sulcus is that going to be the one piece IOL that can cause the mimicking viral associated anterior uveitis with a high IOP. So which is the IOL that you implant for the sulcus IOL in this case?
I'm not sure. Maybe M. Yeah, maybe M. Just the Alcon one. I'm not sure because I did not do a surgery in this case. Yes, sorry.
Yeah, because of one thing that we see more and more in this era, and let's say we working on this for the research is if you do the one piece IOL in the sulcus, it's more and more likely to have the IOL related anterior uveitis, and when you see it can cause a very high pressure, a little bit of pigment in the anterior chamber, and remember when you have the CMV PCR positive, it means that you found the genome of the CMV, right? But if you have the CMV is right in the cells, it may be coincident. But if it just have the CMV retinitis, that's super hard to tell. I don't have any answer for that. But let's say the thing that you bring up is, I think, is important though to work out.
Yeah. Yes, and sorry. Yes, and one thing that I want to mention in this case, because this is a non-HIV patient present with a CMV retinitis, so it's a different phenotype of the CMV presentation. So that may present. So this case presents just only the granular CMV retinitis in the infratemporal of the fundus, but you will see a little bit of the hemorrhage in the periphery of the fundus in the supratemporals and supranasal. So yeah, so I think that this is like one of the phenotype that have like maybe a pan-retinal occlusive vasculitis also present concomitant with the CMV retinitis. Yeah,
I would agree with you with that. I've noticed the same thing that in patients who are, other immunocompromised status, whether they're older or whether they have diabetes, even if it's controlled diabetes, I've noticed that they can have a profound vasculopathy, which is really highlighted when you do fluorescein angiography, that you can see areas of non-perfusion that you clinically cannot see. and sometimes just very minimal retinitis, at least in the beginning. Yeah.
I think there maybe it's like some T cell defect. I think may I suggest you something? You
Yes.
send John the specimen for the MDS. Okay, sorry. Go ahead.
I have another comment that to determine if the course is by the IOL or the CMV, maybe we can try real-time PCR to see the number of copies of CMV, so that if there is an increase in number of CMV, that is more likely to be the course of this patient.
Yeah, and also what might be cheaper and quicker is just to do an anterior UVM, just to see if there's any IOL issues.
Totally agree. Totally agree. The UVM, I'm totally agree. To look at the IOL, where is the IOL position, there's going to be another cost. And if you carefully look at the anterior chamber, which type of cells, is white blood cells, pigment, or is red blood cells, that also helpful.
Mhm.
Thank you.
Okay. For the last case in our session, from Dr. Thanawadi Ratanapong from Chulalongkorn Hospital. Right now, he is a uveitis fellow at Chulalongkorn.
Okay, good evening, everybody. My name is Thanawadi Ratanapong, uveitis fellow from King Chulalongkorn Memorial Hospital. It's a pleasure to be here at the third CKPU. And now let's get started with the first case. This is going to be a case series. Okay, the first case is a 39-year-old male with no underlying disease. He came with a history of blurred vision in his right eye for 1 week. On examination, there was the visual acuity was 20/20 in both eyes, and the right eye shows a sign of inflammation. They were injected conjunctiva, corneal granulomatous, and stellate KPs inferior, and the white blood cells in the anterior chamber was graded at 3+. The lens was clear. On dilated fundus examination, there were scattered areas of peripheral retinitis with no vitritis. The diagnosis was made as having acute renal necrosis in his right eye. This is an atypical presentation of viral necrotizing retinitis in immunocompetent patient. The patient was admitted. Aqueous specimen was sent for PCR detection of human herpes viruses, and the intravenous acyclovir and intravitreal ganciclovir were given. 2 days later, the aqueous PCR result came out to be positive for varicella zoster virus. And at day 10 of admission, the retinitis subsided, and at 2 months follow-up, he is still taking oral acyclovir, and there was no recurrence of retinitis. The second case is an 69-year-old female with underlying disease of dyslipidemia. She is also an immunocompetent patient. She came with 1 week of flutter in her right eye and 2 days of blurred vision in her right eye. The visual acuity was 20/100 in her right eye, and there were diffuse pigment stellate KPs, 1+ cells in anterior chamber. On dilated fundus showed peripheral retinitis, retinal vasculitis, optic disc edema with vitreous haze and clumping, while the left eye was unremarkable. In this case, the result of the aqueous fluid PCR was also positive for varicella zoster virus. So she was diagnosed as having acute renal necrosis in her right eye. The intravenous acyclovir was given. On day 3 of admission, there was an apparent progression of retinitis. So the IVT or intravitreal ganciclovir was given for adjunct. After that, there was still a progression of retinitis to posterior pole. At that time, we considered if she's having a drug-resistant strain of varicella zoster virus. So the intravitreal medication has changed to foscarnet. We also treated the inflammation with high-dose prednisolone. And after that, because of the financial problem, she's got another 2 injections of intravitreal ganciclovir. And the intravenous cyclovir was continued for 14 days and switched to oral valacyclovir. At follow-up 2 weeks, the retinitis subsided and there was no sign of active inflammation. The third and the longest and the last case is a 31-year-old male with first diagnosis of HIV infection with unknown CD4 level. He was referred from another hospital with a chief complaint of progressive palate blurred vision in his left eye for 2 weeks. On examination, the right eye was unremarkable. In the left eye, the visual acuity was counting finger at 2 foot. The IOP was a little bit low, 8, and severe inflammation of anterior segment, injected conjunctiva, variable size, whitish KPs predominantly at the inferior cornea, and the anterior chamber filled with 3 plus of bright blood cell and 2 plus of flare. The cornea was clear. On fundus examination showed high level of vitritis, about grade 3. There was scattered areas of peripheral retinitis and vasculitis. The laboratory investigation from the referral hospital showed a normal CBC, the serology positive for anti-HIV and pending result of CD4 level. The RPR was reactive and the TPHA was reactive. At that time, he was diagnosed as having ocular syphilis in his left eye, and management will admit lumbar puncture and intravenous aqueous penicillin G. On day 3 of admission, we saw apparently progression of peripheral retinitis posteriorly, and there was also increase in inflammation and new choroidal detachment in full quadrant. The diagnosis has been revised and we came back to the initial investigation and we request for a title of the RPR. We asked to the referral hospital and there was 1/4. We also repeated the RPR in our hospital, which came out to be non-reactive. And at the same time, the CD4 level result reported to be 21. Now we had made a new diagnosis of viral necrotizing retinitis in his left eye. And the management were anterior chamber tapping for aqueous PCR for human herpes viruses. Intravitreal ganciclovir was given and we started the intravenous ganciclovir. In summary, in this case, at day 1 of admission, he was diagnosed as having ocular syphilis and the aqueous penicillin G was given. At day 3, we revised the diagnosis and the intravitreal ganciclovir, intravenous ganciclovir were given. At day 5, the aqueous PCR result came out to be positive for varicella zoster virus, and the inflammation increased. There was severe inflammation in anterior chamber, cells, flares, and vitritis grade 4, and also 4 quadrants of choroidal detachments. So we start the high-dose prednisolone. And after we think the inflammation was controlled, then we go on for surgery. This is an intraoperative video. There was extensive retinitis, vasculitis, and intrarenal hemorrhage. The vitrectomy was done. The choroidal detachments were also drained and they were hemorrhagic in content. The laser photocoagulation was done 360 degree and the eye was filled with silicone oil. And these are the pictures compared the fundus from post-operative day 1 until day 10. You can see there was improvement of retinitis and the laser reaction was turning into a scar. In summary, my 3 case series shows a typical presentation of viral necrotizing retinitis, severe vitritis in immunocompromised patient, and lack of vitritis in immunocompetent patient. There's also a role of an adjunct intravitreous phosphokinase in case of unresponsive to intravitreous gangcyclovir or intravenous cyclovir. And also the last case is to show that there can be an important role of surgery in selected uveitic cases, and appropriate timing of surgery is very important. And that's all.
Yes, I want to ask Dr. Vichak and Dr. Gonzalez that in the case 2, it's very interesting that what is the best timing for giving the steroid treatment, oral prednisolone? Like in the case 2 that the patient also have a severe vitritis and also the severe retinitis as well. What is the best timing do you think to have or do you think to give oral prednisolone to patient?
I think for me, it's really a case by case basis. I don't think that I don't think it's been really particularly well studied that, during, day 1 through 3 after starting antivirals, you commence prednisone. It really depends on the level of inflammation, and whether or not with antivirals alone, the patient's getting better, including with respect to inflammation. Sometimes even despite antivirals, the patient continues to have significant vitritis. There's a concern for developing significant membranes that are putting the retina at risk for detachment. So it really kind of just depends. And that means that there is often frequent follow-up with the patient at that time so that you can really quickly pivot in terms of determining, okay, now I need to start steroids, prednisone, to manage the inflammation. It's clearly not going to get better with antiviral treatment alone. So I don't always start everybody on prednisone after we start antivirals. It really depends on if the inflammation is getting better. And, not everybody gets 1 milligram per kilogram per day of prednisone. It may be lower depending on how robust that inflammation is.
And
after for me, I do the same. I select case by case basis. I tend to start prednisolone at least 48 hours after the beginning of antiviral to make sure that you have the level of antiviral enough to fight the virus. And then, when the patient presented with ARN, the component is not only from the virus damage, is from the inflammatory response from the host. So I tend to start the prednisolone in case of cystoid macular edema or significant vitritis, and try to tap it quite rapidly than the conventional steroid that we use to treat non-infectious uveitis, and make sure that the antiviral is always covered when we use steroid. That is my approach.
And for the second case as well, when you change from the intravitreal gangcyclovir to phosphokinase, that you think it's gangcyclovir resistant, right? What after we treat with a proper antiviral drug, when will you expect to see a response from the treatment before you change the treatment? What is the timing that you think you can wait and see the treatment before you changing? Dr. Vichak.
Well, I think, many times acute retinal necrosis is not, it doesn't respond immediately after you initiate the antiviral. You may wait for 2 to 3 days till you can see the response. The retinitis become dry. So maybe you have to wait a little bit. And in this case, I have to declare this is my case. I'm not sure because we try to use both an intravenous acyclovir and also adjunct with intravitreal acyclovir, but the retinitis seems to progress. So I'm not sure about that. So so finally I consider using intravitreal foscarnet for a dose, and that's and unfortunately the patient improved and the retinitis is stopped. Yeah. So, but I also have a question that if you suspect the viral resistance, like this case, what would be your approach? Do you send the PCR for CMV to prove the resistance for every cases, or you just switch to the foscarnet that is less likely to be affected by the viral resistance?
I think it's challenging to invoke resistance, so early. Antiviral resistance for HSV and VZV is extremely rare. For CMV, we see that in patients who are immunocompromised and this is from the transplant literature, right? Solid organ transplant literature, where we have patients who are chronically immunosuppressed for solid organ transplant who are as prophylaxis on prophylactic valganciclovir, but low dose, and that chronic low dose exposure can lead to the development of CMV resistance. But in the eye, I don't think we have that kind of. I'm not sure that necessarily happens. So I agree with Wijak that you can have progression of disease even after a few days of being on antiviral, because it takes a while for it to kick in, for viral replication in the eye to stop. And maybe you can help things along by using intravitreals. The other thing I was going to say is that antivirals, all they do is inhibit viral replication, right? So if you have an immunocompromised host, and they have a deficient immune response, you can still have viral replication because their immune response is not able to attack the virus, right? So if you have somebody with a low CD4 count, they're going to still potentially have progression despite antivirals because they don't have a very good immune response against the virus.
John, they also have one question from Kay in the chat that about the role of IVT ganciclovir adjunct to the IV cyclovir. Yeah. What do you think?
I mean, I don't know if that's necessarily better. I think that certainly that's reasonable to use intravitreals as an adjunct, and I think I'm not even up to date with some of the retinal literature that suggests that maybe there are occasions when intravitreal might be reasonable. But I mean, certainly it makes sense if, it's often, we don't admit every patient with ARN to the hospital for IV acyclovir. We will use 2 grams oral valganciclovir, 2 grams orally 3 times a day to manage people with viral retinitis. They have to have close follow-up, of course. So if you're concerned about your patient being able to afford tablets or to be able to get appropriate therapy, then of course you're going to admit them, giving them IV acyclovir. But while that's happening, you can still have progression within a matter of 5 hours, right? And so if you're concerned that your patient's not going to actually get a hospital bed, get the IV in their arm for the next 5 hours, it makes sense to use intravitreal ganciclovir in the clinic before they get them into the hospital, for sure. So I think that it makes sense to use that on occasion.
Yeah, John and Si, I also have one comment for the last case, because the last case is the biliary profile immunocompromises with the CD4 of 21, but because of it have a lot of uveitis and a lot of inflammation. If somehow the local inflammation is not aligned with the systemic inflammation. Right. And in this case, because of the syphilis titer is low titer going up, but because of these cases, one history that misses, these cases have partially treated another infection with I I cannot remember the systemic amoxicillin with carbolinic acid, the augmentin. That can be partial treat though, but this is the first time that we see the case like this, and also have the very, very uncommon of the massive suprachoroidal hemorrhage in the case. Yeah. Yeah. So if anyone have any comment on this, can help us out, really happy for that. But we're gonna do the case report for
Recording
this.
stopped.
Yeah, we don't know what is really the cause. Yeah. Thank you.
Recording in progress.
Well, I think it's time for the first session to be end. Thank you for all panelists and commentators. And we're moving on to the second part of case-based symposium, and more exciting cases are coming. I would like to turn it over to Dr. Vipada and Dr. Thanapong. Thank you. Thank you, Dr. Translator, Dr. Busrat.
Thank you.
Thank you, John, and all of the panelists are still with us. So we 1 hour late though. So let's go for another session. Okay. We're gonna try to make it in time. Thank you all for staying with us. So
Sure.
maybe,
Okay.
yeah, go. Okay, let's go.
Okay, so next is my fellow. He is a retina fellow in Khon University, Dr. Napat. He's gonna present again the back posterior cases with very complicated case. Okay, go on. Don't be late. All right.
Okay, can you see my slide?
Yes.
Okay, good evening. My name is Napat Oprayun, Retina Fellowship from Sinokrine Hospital, Khon University. Today, I would like to present an interesting case with viral-related eye disease. A 35-year-old Thai man, he presents with progressive visual loss of left eye for 2 months without any prior treatment. Then he experienced red eye and photophobia of left eye for 3 days. Has medical history, he has got an HIV infection, which diagnosed 1 month before. His CD4 count was 35. Ocular examination in the right eye, visual acuity was 20/60, IOP was 10. Conjunctiva and cornea were normal. There were 1+ cell in anterior chamber, 4 millimeters pupil with reverse IAPD positive. In the left eye, visual acuity was counting finger at 2 feet, hypertony, inject conjunctiva. The cornea was edema with diffuse pigment KP. There were 1+ cell in the anterior chamber, posterior synegia and NVI. Fundus examination of the right eye. Vitreous haze grade 0 with some vitreous cell. As you can see, there were circumferential retinal infiltrate. If you look closer at the temporal side, the infiltrative lesion in some area will not involve vessels, like crack mud appearance. And there were few flame-shaped hemorrhage and cotton wound spot in the posterior pole. Fundus photo of the left eye, the image quality wasn't good because of corneal edema and some vitreous haze, but you can still see the retinal infiltrate at the superior retina, and there was inferior retinal detachment which cannot be shown in fundus photo. So the diagnosis in this patient, progressive outer retinal necrosis of both eyes and chronic retinal detachment of left eye. Management in this patient, we perform anterior chamber tapping in the left eye for PCR virus, and we give intravitreal cyclovir for in both eyes, and we give intravenous cyclovir while waiting for the PCR result. And we consult infectious medicine for the management of HIV and other opportunistic infection. They investigate the patient and found that the VDRL and TBHA were both reactive. So they give the patient intravenous penicillin G for 14 days, and they start antiretroviral therapy at day 5 after admission. At day 2, the PCR result came back with positive for both varicella zoster virus and CMV. So we switched the IV medication from acyclovir to ganciclovir. At day 7, there were some improvement of the retinal infiltrate, especially at the temporal side, so we continued the treatment. At day 8, there was retinal detachment in the right eye involved macular. Sorry, there were no fundus photo in this day. The visual acuity was dropped to hand motion, and so we did the operation with tracheotomy, with endolaser, with intravitreal cyclovir and silicone oil in the right eye. Intraoperative finding, there was retinal infiltrate 360-degree and diffuse small retinal holes with retinal necrosis. And we continue the intravenous cyclovir. At day 11, post-operatively, the retina was attached. We improved to 2400. At day 15, the 2-week course of intravenous cyclovir and penicillin G were completed. But unfortunately, the patient has an episode of generalized tonic-clonic seizure. So we consult the neurologist and the patient was transferred to internal medicine ward. After that, he cannot maintain the face down position. At day 16, the inferior retina was detached and VA dropped to counting finger at 1 feet. So we advise the patient to remain in face down position. At day 22, the ocular condition was stable and the medical condition was improved. So they discharged the patient and we made an appointment as outpatient. At day 32, the visual acuity was at the right eye was hand motion and in left eye was no light perception. And as you can see in the fundus photo, there was numerous retinal hemorrhage in the right eye with dilate retinal vein. So we suspect the secondary RVO, which with a combination of RVO and retinal detachment, the visual prognosis is quite poor. So we just observe the patient. At day 54, visual acuity was no light perception in both eyes, and there was still detachment of retina and retinal necrosis with hemorrhage. So there was no visual potential in this patient. This table compared 3 viral retinitis diseases. PORN is typically occur in the immunocompromised host caused by varicella zoster virus. This is the cause that we choose to start with acyclovir in this patient. Initial lesions are at the peripheral retina, then rapidly progress to posterior pole, mostly no uveitis and rarely vasculitis. The prognosis of progressive retinal necrosis is poor. Our retinal detachment occurred in 70% at a median of 4 weeks. Final visual acuity was no light perception in 2/3 of patients. There were studies shown that combination of intravitreal and IV antiviral may improve visual outcomes. And there were another study that shown that combination of IV, IVT, and antiretroviral therapy may improve visual outcome also. The most common cause of PORN is varicella zoster virus. However, there were a case of PORN with PCR positive for both zoster and CMV but have reported. In that study, the treatment were weekly IVT cyclovir and oral valprocyclovir. The outcome was resolution of retinitis lesion, but the final VA was PL. Thank you for your attention.
Thank you.
John Kay, would you have would you like to comment on this? It's like the zoo. It's a lot of pathogen. What do you think?
That's my guess.
I guess, is this a pretty typical case of uveitis for you, Kay?
Right.
I mean, I don't know what to say because, I mean, the patient was VPRL positive, also had TB meningitis, also had CMV and VZV. I mean, it's hard to know. I mean, I think that made sense to switch over to ganciclovir IV. I guess the question is, where did things go? What happened when the patient redetached with all those hemorrhages, and I forgot because of. You guys think it was because of positioning issues because he wasn't initially able to position face down, or
still, yeah. The redetach that we noticed is just after the patient got a seizure and cannot position face down. But hemorrhage, the massive of hemorrhage is just happened after that to make it worsen again. So maybe 2 episodes of complications separately. But interestingly, we got another case that got massive hemorrhage, but not suprachoroidal hemorrhage as the case of Dr. Nato, but just massive, like severe of CRVO, something like that, massive hemorrhage after starting the antiviral, and lesion get improved, and after that for a while, don't know why he got like massive hemorrhage after that. Another case will coming soon.
Can you ever have a seizure intense enough to cause Terson's syndrome or something?
Yeah, I don't know.
Oh.
Yeah, it's possible. That's a good point.
Yeah.
Yeah, may I have one more comment? Thank you, Napat. That is the very impressive presentation. I love it. Thank you.
Thank you.
Okay. One thing is, when you have massive hemorrhage in the retina, it's possible because of its occlusive bronchitis, right? So you can have like a lot of non-perfusion area. You can have the complication for that. But in our case, is the suprachoroidal hemorrhage that another mechanism. But the thing is, you can have a lot of pathogen that possibly the cause of the clinical presentation. I'm totally giving you, I don't know, but we may need to treat all. But one thing that I would like to point out is the CMV live in the white blood cells. So when you see the CMV positive, it means that you see the viral genome that detected by the PCR. It doesn't mean that it's pathogenic, but it's a good idea to treat it because we don't know if it's pathogenic or not. I'm totally agree with you, John.
Yeah, I mean, the only way to be sure is, this is not routinely available, but is to do RNA sequencing, and then you can, determine if it's active, but that's not widely available. So, yeah, it makes sense.
You can make it available, John.
That'll be Dr. Dewan's area.
John, bring some tools back. Some samples back to San Francisco. Give it to Thuy.
Maybe you bring me back. I would like to go back. Maybe not till. I can send you after. Okay, go ahead.
All right.
Go ahead.
We have to move to another case from Dr. Pimpisa from Vajira Hospital. So please.
Yes, let me introduce my.
Yeah, thank you.
Yeah, sure. Okay, so this is Dr. Pimpisa. She is the beautiful resident, 30-year resident from Vajira. So she will present the case. Okay, Dr. Pimpisa, please.
Go ahead, ready for it.
Sorry. Okay.
Okay, let's move to the 16th. My name is Pidisa Utishaipan, third year ophthalmology resident of Vajira Hospital. First of all, it's such an honor for giving me this opportunity to be representing here. Let's start with a 40-year-old Thai male with sudden onset of pellet blur vision in his right eye. 1 month prior to admission, he was diagnosed with a CD4 count was 1 cell per microliter. He still had normal vision and negative on routine ocular examination. 5 days prior to admission, he presents a group of shingles along right trigeminal nerve dermatome. 4 days later, he presents with alteration of consciousness and was diagnosed for BCV encephalitis. Review of the uveitis system are negative except prior history of chickenpox. His CT brain and CSF analysis were consistent with BCV encephalitis.
So when he gained conscious, he complained of acute painless visual loss on his right eye. VA was right perception on his right eye and 20/25 on his left eye. Normal eye pressure in both eyes. There was no anterior chamber inflammation. Pupil was 3 mm sluggish react and RAP was present. Vitreous cell was half plus, mainly red blood cell. Fundus examination of his right eye showed marked edematous and blurred margin with marked dilate and tortuous retinal vessel and generalized retinal edema and dot blood hemorrhage. There was absence of any retinal infiltration and questionable phlebitis here. Posterior pole was foul pale and edema with cherry red spot on fovea. Left eye was unremarkable. The previous information is naming as 40 years old Thai male age patient present with a unilateral retinal vascular occlusion, vasculitis, optic neuritis without retinitis on right eye following shingle and varicella zoster encephalitis. So here are the differential diagnoses of acute unilateral posterior uveitis with optic neuritis. The first one is infection. So we can think about viral infection. In this case, most likely BCV, tuberculosis or syphilis. And the second one might be inflammation, such as sarcoidosis. The last one, muscular syndrome. So we shouldn't forget this cause. Our investigation showed no evidence of syphilis and tuberculosis. Chest X-ray were found unremarkable. We also performed VTech tapping for PCR, and only VCV PCR was positive. Vasculitis profile were found all negative. FFA of his right eye showed profound delayed arterial filling at 7 minutes and reduced in arterial caliber with normal colloidal perfusion. The first few retinal arterial vessels appear at, you can see, 9 minutes. Okay. And there was no staining or leakage as suspected area of sheathing. No disc leakage and no any leakage found at any phase of angiogram. Left eye were unremarkable. His MRI review enhancement of right optic nerve indicated of right optic neuritis. So for summarize of our patient, he presented with purely occlusive both retinal artery and vein, optic neuritis, history of shingle and PCR from CSF and vitreous confirmed VCV. Given the absence of peripheral necrotizing retinitis, this case similarly would not be classified as ARN syndrome. So we can group our patient as VCV-related non-necrotizing variant of posterior uveitis. In non-necrotizing type of peritic uveitis, had a typical posterior uveitis without retinal lesion. This case were characterized by vitritis, vasculitis, or papillitis. And they have a report retinal vascular involvement in BCV infection, including vasculitis, transient retinal arteritis. However, all occurring in eye with site of inflammation. To the best of our knowledge, there was only one case had been reported earlier. A case of occlusive retinal vasculopathy following varicella zoster infection without an evidence of inflammation in an immunocompetent adult. In 2016, Narayanan reports an 18-year-old female with varicella zoster encephalitis. She presents with blurred vision on both eyes. VA was 360 on right eye and 618 on her left eye. Anterior segment was unremarkable. So far, that examination showed multiple cotton wool spots and well-demarcated zone of retinal ischemia in the posterior pole, with normal optic disc, no vitreous cell, no haze, and no retinal infiltration. Here's a FFA of her right eye, shows increasing foveal avascular zone and multiple area of key capillary dropout in the periphery and posterior pole. So with a diagnosis of varicella zoster related retinal occlusive vasculopathy, she was given the course of intravenous methylpenicillin and intravenous acyclovir. After 6 weeks, her best correct VA in both eyes was 618. Get back to our patient. He was given a course of intravenous acyclovir and intravenous methylpenicillin. Next 2 months, he ended up with visual acuity of right projection and developed neovascular glaucoma. So, thank you for attention.
Thank you. Sorry. Thank you. Excellent presentation, though. Any comment from John, Kay, Plan?
I mean, it just really demonstrates that you have to have, the other part of this, besides using appropriate antivirals, is you have to have, a functional immune system. Otherwise, you can just lose the retina, like in this case.
Yeah. If you look at the OCT, you see all the outer and inner segment is gone. But if you look at the choroid, you still have some patchy. So it's mainly, we all know that the viral necrotic retinitis mainly affect the whole layer of retina. And this is a very good example of the occlusive vasculitis. But the thing is, you have occlusive vasculitis, but really fail retinitis and really fail of inflammation. This happens sometimes. And let's say, as I know, they have some case report that use the zoster vaccine. That's something like this. The patient go blind from the vasculitis, like have ophthalmic artery occlusion or something like that. Yeah, I do remember that. They have some rare cases that can cause vasculitis, and people go back after zoster live vaccine. Yep. Okay. Very nice cases.
Thank you. So in this case, we think that, so patients develop with VCV encephalitis, and that they have a virus that infects the nerve, and they have produced a neuritis or inflammation at the nerve, and they have maybe the compress of both retinal artery and retinal vein, and they produce a pictures of both like a CRAO and CRVO in this case. Maybe, yeah. This is maybe. I think this is a possible mechanism of this case. Yeah.
And I think you should report this case.
Yeah.
This is so nice, and not good for patient, but so nice for education.
Yeah. Thank you.
So one thing that I would like to know, if we can see the early phase of the FA and ICG, that might help. I'm not sure. This is only retinal circulation, or it also has some effect on the choroidal circulation.
No, the ICG is normal. Yes, it affects only the retinal circulation. Yes.
But arm to choroidal circulation is normal, right?
Normal, right? Yes.
So it
normal.
maybe affect the CIA. So that actually nice for education, but not good for patient. You do the best.
Yeah. Yep.
All right. Thank you. We should move on, I think. Yeah. So next, it's going to be from Chulalongkorn University. Dr. Thanaporn is one of our past uveitis fellow, and right now he's our retinal fellow. Is our future. Dr. Thanaporn will present the case. She will practice at Bhumibol Hospital after graduation, and will come back to the Chulalongkorn Hospital as our teacher and our mentor. Thank you. Please go on. Hi.
Thank you, Ajahn Natho. Let me first share my slide.
Sorry. One thing I would like to share for his master in iPad user. She never used any laptop, Mac, just iPad, and you see the presentation. Go on.
So let's start. It's getting quite late. The next, this case is from the uveitis clinic. Before I start, I would like to give a very brief remembrance talk speech towards KT Katai. She's always been helpful to me, and I always look up to her. Even though it's just a brief time that we work together, but she gave me such a positive effect, and I would like her to know that she'll always be remembered and loved. Okay, and I'm very grateful and honored to be involved with this here tonight. Let's start with a case. This case is a 70-year-old Thai female. She's her past medical illness. She's got CA breast, which was in remission for 10 years already. She's post surgery and also radiation therapy. Also, she's got EBV associated B-cell lymphoma since November 2019. She's got post chemotherapy and also radiation therapy, and her neutropenia. She has neutropenic and is on GCSF therapy with the hematomet. She was diagnosed with CMV retinitis on the right eye since September 2020, and she's completed her course of ganciclovir/oral valganciclovir induction for 14 days, and we reduced the dose to maintenance of valganciclovir for another month. But eventually we have to stop the treatment due to her severe pancytopenia. And but luckily her retinitis was inactive, so we had a watchful waiting and observation. Since February 2021, she complained of blurred vision on the right eye, and we found that it was a VMT with cystoid macular edema. So Ajahn Thanapong did a surgery, a combined phaco emulsification with lens placement in the back and with PPV and membrane peeling. And we used TA assisted, so we had a prophylactic intravitreous dose of ganciclovir then. Post-operative, the cystoid macular edema improved for a while, but then post-op for 1 month, cystoid macular edema seems to progress. So when we see a cystoid macular edema, it's always a dilemma in management in infectious uveitis. We always have to think if it's infectious related or non-infectious related, because the treatment algorithm is way different on both sides. If it was infection, you'll have to treat the cause of infectious. So you have to find if there's still active infection, and on the other side, if it's non-infectious, maybe it's post-op inflammation. Could be IOL associated if in UGH or pseudophakic macular edema usually happens at this time. And also in our patient who is immunocompromised, could it be immune recovery uveitis and causing cystoid macular edema? And usually immune recovery has been reports in patients with CMV with AIDS when they get heart therapy and their immune conditions improve. But in our patient, it's non-HIV patient, but there are still reports with GCSF use related, and when immune reconstitution happens, then we get inflammation afterwards. So we decided to do further imaging. FAF seen here on the right eye, you can see the chorioretinal scar as hypofluorescent lesion in the inferior part of this photo, and with active hyperfundus autofluorescent borders, which show some activity, and maybe we need to give an eye on that. For the FA, on the right eye, other than those petaloid leakage of cystoid macular edema, you can see mild disc leakage, but the lesion where we think it's chorioretinal scars I think it's only just hyperfluorescence staining of the lesion without active vasculitis, vascular leakage. On the left eye, it's normal. So in our patient, we think it was not active infection. So we think it could be the non-infectious causes. Her IOL was placed in the bag without IOL donosis, so we don't think it's UGH. And so we had a look of her immune conditions. Her ANC count was on the lower side, about 1,000 to 1,500 for the past few months. And usually immune IRU usually happens in a temporal relation to after immune reconstitution, as is shown in a very good graph from Teng and Hirohiko. You can see events of virus or IRU usually happens after immune reconstitution, and the white cell counts usually is quite high. So in our patient, we think it's just pseudophakic macular edema, and we decided to treat her CME with a local steroid with intravitreous triamcinolone. And we did a course of intravitreous triamcinolone PRN of her cystoid macular edema, and it responded for a while. And then after the fifth injection, we decided to increase the dose of triamcinolone to 4 milligrams, and that's when we could see some active retinitis coming back. Her left eye was still normal, and her ANC count by then was quite good. It was about 3,000, quite normal. So we think this active retinitis, and since she was on a cyclovir of a prophylactic dose, I forgot to mention earlier, but she had zoster dermatitis, so the hematoma gave her a prophylactic dose of acyclovir. So when we see viral necrotizing retinitis reactivation while on prophylactic dose of acyclovir, we think it's her CMVR reactivation, and maybe the cause is from local immunocompromised that we gave her intravitreous triamcinolone. So we decided to give her a local treatment with intravitreous ganciclovir 2 milligrams per 0.1 milliliters. And her retinitis seemed to improve, and we could extend the duration to 2 to 3 weeks. But then after we decided to extend the interval to 4 weeks, then more reactivation of CMV retinitis. So now we think if it was from the inadequate treatment of ganciclovir injection we gave her, the interval maybe it was too far apart, or she's got an emerge of drug-resistant strain of CMV while treating with IVT ganciclovir. But as I think John mentioned earlier about the drug-resistant CMV retinitis usually happens in the condition where viral replication is still allowed in some conditions, such as where bioavailability of antiviral is not enough, and there's host immune is poor, and those virostatic virals is not enough to suppress the viral replication. And so we decided, and in our patient, those conditions aren't present, and we gave her direct intravitreal ganciclovir, which usually gives good bioavailability to the retina. So we decided to continue the same drug ganciclovir and shorten the duration to 2 times weekly, and then once a week. And that's when we get a great response, and the retinitis seemed to subsided. But then when I opened the OCT, and then I found deja vu, still CME still just came back, and now we have a dilemma of but we still have to treat her with antivirals. And our patient here is still following up with our clinic right now, and this case is still to be continued. And I would like to give a special credit to Ajahn Thanapong and Ajahn Vichak for helping me with the presentation.
All right. So thank you for, again, beautiful cases. Once again, we always found something that make us curious about is that the reactive or recurrent of infection, or it would be from inflammation. Meanwhile, we treat the pathogen like cystine macular edema or even hemorrhage, right? My residents always asking me about should we increase doses or frequency of intravitreal treatment in this patient, because we found some new hemorrhage on the retina, even scarring of infiltration. No any active infiltration, but see some hemorrhage or some CME. What should we treat in this kind of cases, right? Okay, and this is the beautiful examination for treatment in variety of presentation. Any comments?
I don't have any real comments. I mean, I guess, you can never be sure. I think the only way to be sure maybe is to, you can do PCR, HC-TAP or whatever, PCR, and see if you have, demonstrable virus. Obviously, that doesn't tell you if the virus is dead or not. You could do RNA sequencing to see if you have transcriptionally active virus, but that, like I said, is not readily available. These issues, progression of disease was not, too long ago. That was a common problem, right? The height of the HIV/AIDS epidemic, it was a big enough problem where we had an intravitreal implant, right? Vitrasert, intravitreal ganciclovir implant that was used because people had crummy immune systems for long periods of time because antiretroviral therapy had not yet been introduced. And so instead of injecting somebody, a couple times a week, you had a ganciclovir-eluting implant. But that's gone now because the epidemic is over, at least in most places. And so there wasn't a market for that anymore. One question, I guess, is, for these cases, I mean, how often do you try either, well, I guess difluprednate, Durezol is not available maybe perhaps here. So that's one thing. But how about just oral acetazolamide?
Yeah, John, that is
right.
It's the major cause of death. So we try to treat it with a steroid. But acetazolamide may be another action and another mechanism. That's a good idea. Thank you. We did not try it yet. Yeah.
All right. So let's move to the last case. The last case is from our 4th-year resident, Dr. Thiratat. Good news. He gonna be glaucoma fellow in Chulalongkorn hospital in next year. We just know that today. Congratulations to you. Okay, let's start. Dr. Thirathат, please.
All right, thank you for the introductions. Can you see my slide?
Yeah.
All right. So, hi everyone. My name is Thirathат Sibunnaik. I'm a fourth-year student from Khon Kaen University, Thailand, and I'll be presenting the last case for this conference today. As a resident, I have no financial disclosure. So our patient is a 30-year-old man who was referred to us with symptoms of blurred vision in his right eye and notable flutters in his left. He also reported my difficulty with walking over the past month, including feelings of heaviness in his right leg. He had no past ocular history or any prior surgical history. Nonetheless, he was diagnosed with HIV infections and has refused to take any form, any form of anti-HIV medications following the diagnosis. Family history were non-contributory and the reviews of system were normal except for difficulty walking. So during physical examinations, the patient's vital signs were all within normal range, and he was found to have oral thrust on his oral examinations and PPE lesions on his extremities. Other exams were non-contributory, except he had decreased motor power and hyporeflexia in his right leg. His sensation was intact. He has no light perceptions of vision in his right eye, 20/20 in his left eye. IOP were normal. His pupils were equal in size but has a positive APD in his right eye. Visual field testing showed inferior scotoma on his functioning left eye, and his EOM were full. Slit lamp examination showed mild injections of both conjunctiva with 2 blood cells and a flare in his right eye, half blood cells without flare in his left eye, and other structures were pretty much unremarkable. So his right fundus photograph show clear vitreous with these diffuse retinal infiltrations and hemorrhages along retinal vasculature with involvement of the lesions at the optic nerve head and fovea. However, the peripheral areas of the retina wasn't captured by this montage image, but it did somehow show diffuse severe retinal hemorrhages beyond the areas of the retinal infiltrations. His left fundus photograph show clear vitreous with a relatively smaller size of retinal infiltrations with hemorrhages of the superior macular areas. The foveal center and disc were unaffected in this eye, which explained why his center acuity was relatively intact. So notably, these frame-shaped hemorrhage lesions extended beyond the areas of the retinitis, and this made us suspicious about the possibilities of associated with a certain degrees of vein occlusions. The OCT image of the right macula show retinal thickenings with abnormal hyperreflectivities of the retinal inner layers, which block the signal posteriorly. And the last scan OCT images of the left fundus show similar appearances in the areas of retinitis superiorly, and 2 lower optical cuts near the foveal center show cystoid macular changes with an abnormal hyperreflectivities in the retinal nerve fiber layers, which is compatible with the hemorrhage on the fundus photograph. So our patient was diagnosed with CMVR of both eyes. The lesions located in zone 1 and 2 in the right, and only zone 1 in the left, with the possibilities of secondary vein occlusions in both eyes. And he was suspected to have a CMV radiculopathy that was the cause of his right lower leg weakness. So CMVR has been reported to be associated with both artery and vein occlusion, which can eventually cause secondary neovascularizations and its complications. Mechanism has been hypothesized to be caused by either vasculitis or mechanical compressions of the vessel from adjacent retinal edemas or infiltration itself. Because of its rarities, there are no treatment guidelines at the moment, but reports has been shown that treatment with anti-VEGF therapy has been can improve clinical causes of many patients. So CMV has been associated with a spectrum of peripheral nerve syndrome in AIDS patients. And one of the more common forms is called lumbosacral polyradiculopathy, which is a rapidly progressive syndrome occurring in about 1% of AIDS patients. And this illness is characterized by low back pain, bowel and bladder disturbances, weaknesses, and CSF profile can show pleocytosis with high protein levels and a positive CMV PCR. Treatment with anti-CMV medications has been reported to prolong survival and may lead to improvement of the neurological deficit. So our patient was admitted and received a 3-week course of intravenous ganciclovir with additional IVT injections. And his lab result came back showing normal basic labs. His syphilis and TB testing were all non-reactive, and we found positive hepatitis B antigen and positive serum CMV PCR. So the CT scan was performed prior to LP and showed no mass or infiltrative lesions. LP was carried out and showing clear fluid with normal open pressure. His CSF profile showed mild pleocytosis and elevated protein levels. CSF CMV PCR was also sent and came back positive. So shortly after treatment, his right eye showed improvement in the sizes and retinal infiltrates. Unfortunately, within a month of treatment, this eye has suffered vitreous hemorrhage from optic disc neovascularizations. So the decision was made to treat this eye with IVT Avastin. And although the hemorrhage subsided, the retina became atrophic. And upon his left eye, improvement in the retinitis areas was also shown. However, during hospital stay, flame-shaped hemorrhages increased in numbers and sizes with worsening of macular edema on OCT scan. As such, we decided to give him Avastin intravitreally. And on following examinations, the macular edema subsided with residual atrophic scar in the superior macular areas. And after being discharged from the hospital, plans were made for the patients to have maintenance therapy with intravitreal ganciclovir injections. So, in summaries, this is a 30-year-old HIV-positive Thai male who presents with blurred vision on his right eye and floaters on his left. He experienced difficulty walking for 1 month. So he was diagnosed with CMVR of both eyes with possibly faint occlusions and CMV radiculopathy. His lab and LP results confirmed the diagnosis, and he was treated with additional IVT and anti-VEGF for complications of retinal vein occlusions. And his symptom and sign responded well with anti-CMV and heart therapy. So lastly, I just want to thank Ajahn Vipada for giving me these opportunities to be part of this wonderful event. And thanks you all for your very kind attention.
Thank you, Tirathad. All right, so this is our last case, and it's very late now. I think everyone gets sleepy. Okay, any comments from John and Nato? Wake up, please. Okay.
Was your dog chewing his foot off?
All right.
Yes.
No, I mean, in summary, these are all great cases that everybody had. You should all be commended on really excellent presentations, really fascinating cases. Actually, for me, it was really interesting because, I mean, right now, just from today's discussions or talks, my impression is that all of you still see a fair amount of HIV/AIDS and frequently uncontrolled HIV/AIDS with, really classical presentations, almost like this parallel world of this pre-heart era, which is, very rare for us, at least for me. Even in San Francisco, it's not super common. So very interesting that still seems to be a big, a big source of uveitis here.
Yeah. For the comment, thank you for the very wonderful presentation, Tiratat. For the left eye, do you think is the mostly is the ocular vascular occlusion, or is combined with retinitis? Because the treatment that you use is mainly anti-VEGF, right? So can you comment on this?
So on his in his left eye, I think the mechanism of the flame-shaped hemorrhageous lesions is from both the retinitis lesions with combinations of retinal vein occlusions. So apparently, right now in the medical literature, there are no guidelines to treat this macular edema from associated vein occlusion from retinitis. So to answer your question, I think it's from both mechanism. Ajanato.
Okay, can you go back to the picture again? So if you look at the picture, I'm totally agree with you. These cases is more likely to be like vascular occlusion, because if you see many parts of the hemorrhages, cotton wound spot, and also the vascular occlusion. But you really need to think this might combine with retinitis. When you treat it, for me, I gonna treat both because of it's VEGF driven causes by the occlusion, but it also can be another infection that can cause this as well. So 9 cases. Yep.
Oh, but to me, I think main part is infection, because this case is a HIV positive patient with very low immune. Actually, this is not my case, and I never had a chance of inject Avastin in CMV retinitis with retinal hemorrhage. But interestingly, it's getting improved, but maybe from the prior long duration of intravenous ganciclovir for 3 weeks, and maybe it's getting better, but still left some hemorrhage, and maybe luckily improve when we inject the Avastin.
Yeah, we have
I'm not sure.
This discussion of this point before in Asia diseases. Remember, because of this case, you already treat systemically for the CMV, right? So that should cover the CMV retinitis. But remember, even when you have the non-perfusion area, that VEGF driven in some level. In the old day, we also talking about the use of anti-VEGF in the patient that have CMV, but the patient have so much extensive non-perfusion. And when VEGF just come, we fear about maybe the anti-VEGF that we give gonna cause more non-perfusion and more ischemia, but it become not. VEGF become like have benefit on this. For me, it's okay to inject VEGF, but I might not inject that like more frequently. Maybe just 1 or 2 that should be enough, because the major cause is infection. Totally agree with you. Yeah.
Okay. All right. Thank you.
Yeah, I think we are done, right? Almost 100 people said with that. Thank you so much. John, would you like to say something before we close the session?
No, I mean, I really enjoyed today's session. Netta, you should be commended on being able to organize this so quickly. And I'm really glad that we were able to have our third session a year late because of the pandemic, but we were able to make it happen. And so nice to see so many friendly faces from before and new up and coming future uveitis specialists. Really a lot for Thailand to be proud of.
Yeah, I'm very happy to see the newcomer. Welcome everyone, and we would like to have more. Yeah, and thank you, John, to make KT like the lecture. Yeah, and we're gonna have like the KT lecture for every CKPU.
Great.
Would you like to say something, Kay?
Yeah, just gonna say good night to everyone, and we'll see you. I have to come back to my house. Okay, and see you tomorrow,
And then
John.
something. Why don't we open our camera and take photo together?
Yeah, sure.
Ah, good idea. Okay.
All the audience, all the presenter, please open your camera and.
ปิดจอนะ
Yeah.
จอนั้น
Each other and then.